Povar is a longtime Temple Mica member who most of us know as just Gail. She practiced internal medicine with an emphasis on geriatrics for over 40 years and disappointed a lot of patients when she finally decided to retire a few years ago. Over her career, she has taught clinical medicine to medical students and residents, nurse practitioners, and physician's assistants. In addition, she's taught medical ethics to not only medical students, but also undergraduates and law students. Since she retired, Gail has devoted considerable hours of volunteer time to COVID-related endeavors. She's here today to address many topics of interest to those of us in wise aging. This session is being recorded so that those who cannot be here today can still learn about this important and perhaps even life-saving topic. As Gail makes her presentation, if you have a question for her, please enter it through chat to everyone. Sid, in his usual lunch and learn role, will pass along your questions during the Q&A section at the end of her formal presentation. At this point, I would like to turn over the program to Dr. Povar.
That's Gail to you, Barbara, and thank you. And I'm going to allow or ask my esteemed, there, okay, and soon we're going to get a shared screen here, I hope.
I hope so too. Hold on. Okay.
This is a very educated audience, so some of this may be review, but if it's review, I hope it still proves to be helpful review. And I want you to know that I did look at the questions that were submitted initially, and I've tried to answer some of them in the text of this, and any additional questions I hope I've left sufficient time for at the end. So the subject matter, as you know, is first aid and other health topics for seniors. Next slide. What we're going to do today are 5 things. We're going to discuss key health issues: falls, heart attack, stroke, and other risks. We're going to talk about preventive interventions and acute responses. We'll review important preparation for unexpected events. We'll go over briefly what a home first aid kit might look like, and then I'll respond to additional sent-in questions. Next. So these are based on a number of studies between 2014 and 2018 in review of Medicare data. The 3 top reasons why people over the age of 65 go to emergency rooms: nonspecific chest pain, superficial injury and bruises, and musculoskeletal pain, not including low back pain. And before we go to the next slide, I want each of you to think about what you think causes people to show up with superficial injuries and musculoskeletal pain. Next slide. If you thought that falls were the answer, you would be right. Falls among those over 65, 30% reported falling at least once within a 365-day period. In that same period, there are an average of 29 million falls, 7 million injuries. Pay attention to this: 27,000 deaths and 2.8 million ER visits. 30% of those who went to the ER had more than one fracture, one or more fractures. And it's important, people who are hospitalized after a fall have a significantly lower life expectancy than those who go home. Next slide. So how do we prevent falls? There's a lot of literature out there, but these are the 3 buckets. 1, good lighting. 2, get the hazards out of the way. And 3, add safety measures. Next. We'll talk first about good lighting. Very important to have both indoor and outdoor traffic areas well lit. If you are going to go into a hallway at night, have a night light or a light on in the hallway. Don't feel your way in the dark and then turn on a light. Many gerontologists recommend that you make sure you have a light switch next to the bed that turns on the light in the room, particularly the pathway to the bathroom, so you're not getting out of bed and trying to walk in the dark. And finally, keep flashlights accessible in all of your rooms so that if the lighting doesn't work, you're not in the dark. These are critical interventions and they're easy ones to do. Next. So we talked about ensuring good lighting. Now let's talk about removing hazards. This is the big one. And those of you who have heard me in my office know that I harp on this. Area rugs are a risk. We all love them. We have them. I've got them in the house and I look at them and I go, oh my God. If you have to have an area rug, for instance, one that you stand on the sink or in your bathroom, as opposed to wall carpeting, make sure it's got a non-stick backing so it doesn't move. Also make sure it has smooth edges. If it easily rolls up or flips over, it's dangerous. That's how people catch a toe and they fall. And I can't tell you how many people I've sent to the ER because of that. Second, after area rugs is clutter on stairs and walkways as a cause of tripping. Don't use your floor as a storage facility. Get stuff off the floor. And if you want to minimize going up and down stairs, consider a stair basket that either hangs from the banister or is against the wall, so it's not between you and the banister and your path, and keep your stuff in there and then carry that up. And if you're going to carry it up, make sure you always have one hand for the banister. Finally, fix uneven steps. It's very common, particularly in older homes, for risers to be uneven heights. Your body has a kinetic memory and it thinks, oh, it's going to be the same height for the next step as for this one. And when that's not true, you fall. So if you've got uneven steps out of doors or uneven steps indoors, or that you have steps that are chipped or the lip is broken, get them fixed. And this is the last one is an important one. I have a little 11-pound poodle. About 5 years ago, I fell down 5 stairs because the poodle and I got our signals crossed on who was supposed to be where. You have to watch for them. Dogs and cats aren't paying attention to you necessarily. You have to pay attention to them, and tripping over them is a risk. So remove the hazards and focus, please, on try to go around your house, look at the lighting, look at the hazards, and do a visual map of where your fall risks might be. And if there are sometimes fairly easy fixes to reduce the risk. Now, once you've gone through and looked for the things you can improve or you can ensure or remove, what else might you consider doing? Next slide. Add safety measures. So universally recommended in age-in-place strategies, grab bars in the shower, in the bath, next to the toilet. A lot of people say, well, I can grab onto the faucet or I can grab onto the soap dish. Those things are not intended to hold your weight necessarily, and they're often not in the right place to sustain you if you feel like you're falling. So make sure you've got something that's really sturdy to hold on to and use it prophylactically, getting in and out of a tub, getting up and down from a toilet. Different aging happens differently for different people. Some people well into their early 80s or mid 80s have excellent balance and muscle strength. Others don't. So be honest with yourself and make sure you take the appropriate precautions. Put a bath chair or a bench in the shower, especially if you've had a medical illness or surgery, so that you're not standing under a hot shower, get dizzy and fall down. Get a non-slip liner for the shower or bath, or put the strips on the floor. Bathrooms are one among the most dangerous places in the house for the elderly. Now, in the kitchen, move commonly used items within easy reach. Climbing up and on and off stools is not a recommended way to avoid falls. So the things, especially heavy items, make sure they're somewhere you can easily get at them without throwing yourself off balance or having to climb up on something. Consider investing in a reach extender. You've seen them. They have these little clasping mouths, and they have about a 3-foot rod, and then there's a clasp at the bottom that you operate the mouth with. Please, the jaws, please consider getting one of those. And finally, and this is super important, no sloppy slippers in the house. This is another way you trip. Wear well-fitted slippers in the house with rubber bottoms or other non-slip bottoms. So these are the things you can add. We talked about ensuring lighting. We talked about removing hazards, area rugs, steps, watching for pets. These are the things to add: the grab bars, the chair, non-slip liners, reach extenders, walking shoes, and keeping things in easy reach. Okay, let's move on. Why don't we take, and this is a resource. The CDC has a wonderful safety brochure. It's available online for printout or download. And I would highly recommend it if you want to review the sorts of things in even more detail that I just covered.
Next.
Yep. So one of the questions that came in is, what should we do? This is what we call secondary prevention, right? Primary prevention is keeping you from falling in the first place, but what happens if you fall? If you live alone, that's a particularly scary scenario. So I did some research, and pretty consistently across a lot of different rating mechanisms, these 3 devices came up with good reviews, both for effectiveness and cost. Most of these will have an upfront cost and then a monthly cost, and the upfront cost can be at $100 to $200 or less. The monthly cost can be between $7 and $20, depending on how many bells and whistles you choose. Many of them will simply send an alarm to 911. Some of them can be programmed to send an alarm to a family member, but all of them won't work if you don't wear them. And that's the most common reason why they fail to work, is that people don't put them on. The Apple Watch does have a program that some people tell me works quite well. That's a fall detector. And just for those of you who are futurist, I know Mr. David Diskin is, there are devices now being used, for instance, in assisted living and nursing facilities, where there are wireless monitors at 3 different heights in the room, and they learn what the person's normal ambulatory height is. And if someone falls below the level of detection of the unit, after 30 seconds, those units are alert, either a nursing station or 911 or a family member. So, eventually we'll be able to have smart houses that know when we fall and tell somebody about it. Next. So we've talked about falls. On to the next subject, chest pain. So a 75-year-old woman wakes up with an odd aching in her shoulder, no chest pain, coupled with slight nausea and sweatiness. What do you think is going on? You don't have to answer, but just think about it. Next. If you guessed that this could be symptoms of a heart attack, you would be right. The classic symptoms of a heart attack are chest pain, shoulder, neck, or left arm ache and pain. And you don't have to have all of these. It can be some combination of these. And the chest pain can feel a lot like heartburn, and particularly in women, it's not the classic squeezing pressure-like pain. It's often sharp or heartburn-like. Shortness of breath, sweating, doesn't have to be pouring down sweat, just a light sweatiness like you might get if you were nauseated. Dizziness or lightheadedness, and indigestion or nausea. And sometimes inexplicable indigestion alone is a sign of a heart attack. So how do you know what you're having? You don't. But if your symptoms are intense and they last more than 15 minutes, or they keep coming and going repeatedly over several hours, you should swallow your ego, swallow your pride, and do what? Think about it. What should you do? Should you wake up your spouse and say, drive me to the ER? Should you go online and look up symptoms of a heart attack and what to do? What should you do?
Call an ambulance.
Good. Okay, next slide. Absolutely. Call 911. it's still the case that for what we call widowmakers or left main or left anterior descending artery heart attacks, 50% or more will die in the first half hour to an hour after the heart attack. The ambulances anymore are essentially ambulatory ICUs. Paramedics are well trained in the management of acute ischemia or lack of blood flow to the heart. And you don't want to mess around with being driven. One colleague of mine woke up with chest pain at night, turned to his wife, asked her to drive into the ER, where he was diagnosed with a massive MI. And later I spoke with him and I said, exactly what was she supposed to do when you went into VFib in the car? Doctors are terrible patients. We take that as a given, right? So call 911. While you're waiting for 911, chew a not enteric coated, a plain 325 milligram aspirin. This is the, aside from doing a cath on someone who is having a heart attack and doing an acute stent placement, putting a little tube in to open up the artery, the only thing that has been shown to reduce the death rate from a heart attack is aspirin used this way. So keep the aspirin by your bed, keep the aspirin in the kitchen, wherever you can do so safely. Call 911 and chew a plain 325 milligram aspirin. The only thing I will ask you to do is to check with your physician first to make sure that that would be safe for you to do. Some of you may be on blood thinners, and in that instance, sometimes taking an aspirin is prohibited. So check with your own clinician, but assuming there are no provisos otherwise, call 911 and chew an aspirin. And it's got to be a full strength aspirin. Just look at this slide and memorize it. Okay, next slide. So what about a stroke? How do you know if you're having a stroke? I hope that many of you have had the opportunity to see the public service campaign on FAST. FAST means facial droop, and it's not the entire face, it's the lower half of the face. Facial paralysis involving the entire half of the face is a different thing, but particularly what we're looking at is a droop right here or right here. Arm weakness, drift, or drop. So it's, if you suddenly find that you're not able to lift your arm, or you go to grab something and your strength is missing. And this is sudden onset. This is not gradual. That's a warning signal. And finally, speech difficulty. And that can be difficulty finding words, not the kind that we have because we're all getting older, but suddenly you're mixing cat and dog and door and window and kitchen and living room repeatedly. You can't, it's coming out like word salad, or you can't articulate. You're slurring or mumbling. So facial droop, particularly lower face, arm weakness, and speech difficulty. Let's move on. And the T in FAST is time. It used to be that there was very little we could do about a stroke. Nowadays, just as for heart attacks, there are immediate interventions which can substantially reduce the size and the impact of a stroke in terms of the severity of the consequences. So, and in fact, I am on a committee, we just reviewed a bunch of studies where there are going to be empowering medics in the field to deliver these clot-busting drugs. And since most strokes are obstructive rather than hemorrhagic, this is terribly important. Do not call someone to take you to the ER. Again, swallow your pride, swallow your ego. If you have sudden difficulty speaking, sudden weakness of your mouth, sudden arm weakness, call 911. In this case, do not take an aspirin, but call 911. Okay, next slide. So we've covered heart attack and stroke and falls in terms of the presentation, in terms of the things that you can do in the acute event. But and in falls, we talked about prevention. There are other prevention mechanisms that we want to emphasize because they're super important. All of us would prefer never to have to worry about the previous 3 scenarios. So regular balance exercises, yoga, Tai Chi, or specific balance programs have all been shown to reduce the risk of falls. Monitor your blood pressure and cholesterol. The best way to delay or eliminate strokes and heart attacks is to not have them in the first place by monitoring risk factors. So regular exercise, a blood pressure that is as close to goal as possible without unreasonable side effects, and management of cholesterol. And I should note that while I'm not a big fan of drugs, statins taken regularly, even in people with normal cholesterol who have a family history of heart attack and stroke, and diabetics, substantially reduce the risk of those outcomes. So please listen to your doctors and do what they suggest. The data is very strong. Check with your primary care clinician about preventive aspirin. Many of you probably are taking 81 milligrams of aspirin thinking it's helping you. The data is very controversial. There are people for whom it is clearly a higher risk of bleeding to death than preventing a heart attack. Again, talk to your doctor, but it's not clear that everybody should be taking an aspirin prophylactically. And finally, some of you will have read about vitamin D. There is very modest to poor evidence that it has any value, particularly in reducing the risks of falls. If your particular doctor, and I'm sorry about that typo, if your primary care clinician recommends that you take it, please make sure you look for USP certification. That's the United States Pharmacopoeia. And what they do is if a company submits aliquot samples to them, they will test them to be able to validate that what's on the bottle is really what's in the capsules. Many companies. Somebody needs to mute.
That's me.
Yeah.
I will.
Please mute. Yeah.
It's not all companies will submit. I can tell you, and I'm not being paid for this, that in general, Kirkland's vitamins, the Costco vitamins, are USP certified. Nature Made, I also believe most of them are USP certified, but you can look for that on the label and be careful. There are other certifications that they will put on the label, but they're not USP. It has to say USP. So let's work on prevention, but be aware of what to do in the acute circumstance. Next slide. Yeah.
Okay, there we go.
Okay. So I want to stop for just a minute here for 5 minutes of questions before we go on to the next slide here. Any questions so far on falls, stroke, or heart attack?
We usually do this at the end, Gail, with
Okay.
everybody submitting questions, and then Sid will.
All right. Okay.
Yeah,
that's fine.
I think that'll work better.
That's fine with me. Okay. All right. So a lot of times people ask, what do I do for a particular symptom? But they don't think about what should I be prepared with if in fact I've called 911. What do I have to have? And we generally recommend that you have a grab and go envelope. Attach it to the refrigerator. Some people keep it on the table by their front door. Other people tape it to their bedroom door. I know it sounds macabre, but in the event, it's really important. So think about a place to put it. If you have a cell phone that's on you all the time, you can create it as a file on your cell phone. But the problem is if you're having a heart attack and a stroke, you may not have the presence of mind to be futzing around with technology. So sometimes in this case, old school is better. And lest you think otherwise, hospitals are not on the same electronic health system. We are still in the 1990s, faxing back and forth. And so you cannot rely necessarily, and you can't rely that you'll go to a particular hospital, because if hospitals are too busy, then they go on what's called reroute, and then you're sent to another hospital that may not have your records. So for all these reasons, create a grab and go envelope and have it somewhere easily and accessible and visible. What should be in that envelope? A current list of your medications, including the dose and the timing. For instance, lisinopril, 10 milligrams, 1 tablet twice a day. You should have a current list of your ongoing medical problems and who you see for them. So for instance, atrial fibrillation, Dr. Siegel. In addition, you should have a list of major past problems. So these are the things that landed you in the hospital and may or may not suggest a risk related to the current event. So if you had a heart attack, that needs to be in there. If you have a penicillin allergy that caused hives and wheezing, that needs to be in there. If you had abdominal surgery and a colon resection, even if it wasn't for cancer, that needs to be in there. And this should be reviewed. Those 2 items should be reviewed at least every 3 months and probably more often than that to make sure they're up to date. Make sure that the medications include over-the-counter and vitamins, because believe it or not, vitamins interact with other drugs. Over-the-counter drugs are over-the-counter often not because they're safe, but because they have historical exclusions that allows them to continue to be over-the-counter, aspirin being a primary example. And those drugs interact with drugs that you might need to get in the hospital. So everything that goes in your mouth that's not a food item needs to go on this list. And patches too, things like that, or injectables. So medications, medical problems. If you have an advance directive and a person who's a medical power of attorney document, a copy of that should be in there, and a list of emergency contacts, because those are not necessarily the same. This is really important. I can't tell you as a clinician how many times patients would land in the ED and the ED doc would call me and say, do you have any idea what drugs they're on? Does this person have a history of heart disease? That's a delay in care. While they're waiting to get that information, the patient is either getting care that they need that could be dangerous or getting care they don't need. So please, please, please consider creating this. Next slide. Big one. Remember eyeglasses and hearing aids. This is, again, this is something to share with whoever lives in the house with you. They throw them, keep your eyeglasses, and God, I have to tell myself this over and over again, and your hearing aids, if you have them, in a known place. If they're not on your face, they should be somewhere always the same so that somebody can grab them quickly. Particularly for older patients, it's been found that their care is markedly better when they can hear and respond appropriately to what's going on. So eyeglasses are important so you can read documents that you're given, consent documents.
All right, completing a U.S. record 355 days in space, successfully returning to Earth.
All right, hello. But
Sorry,
please
because I'm running these slides. I can't I
get
can't
off
check
the
the
back, right?
yeah.
So,
So.
and the hearing aids, as I said, that's essential to being able to communicate with staff if you can. And I would add here, if there's someone who can go with you, not by car, but or take you to, who can accompany you in the ambulance or follow behind, having an advocate with you is very, very important. Next. Okay, so we talked about the grab and go envelope, and we talked about eyeglasses and hearing aids. Those are the sort of preparation you can do anytime. Make sure that if you do, God forbid, have to call 911, you can take the important information with you. And this should be part of your review, along with the hazard review and other sorts of things we've talked about. Now, a couple of other things. Cars and other hazards. A significant number of ER visits by the elderly arise from motor vehicle accidents and complications of medication. Keep going. So MVAs are much, much, much more common by multiple fold in those over 70 compared to other age groups. Again, there are preventive interventions. One is to take a senior driving course. And in fact, some of the insurers will give you a break on your insurance if you do this. And I've given you 2 potential programs up there with the access information. The other program, which I would strongly recommend if you've had any neurological diagnosis or a stroke, or you have severe arthritic limitations to neck rotation or shoulder movement, sign up for a dual control car driving safety assessment. These are not cheap. They can cost in the realm of $600 to $1,000, depending. However, what happens is someone goes out with you who has control of the car, and they will evaluate your reaction time, your safe decision-making, and they're there to rescue you from your mistakes. They will take you on local roads and they will take you on the highway. And especially if you have a loved one who is having cognitive disorder, issues, this is critically important. One of the most common accidents among the elderly is failure to assess and safely negotiate a left turn. That has to do with being able to judge the speed and the location of oncoming vehicles, or neglecting to see a pedestrian in the crosswalk. Those kinds of cognitive data assessment evaluations are really only possible in the context of these dual control car driving assessments. I've listed 3 that are options for you. I will also point out that the Driver Rehab Center of Excellence in Chantilly not only does the dual control car driving assessment, but they're the only one I could unearth that actually does rehabilitative car modifications. So for instance, for my father in Florida, he had severe rotation loss of his neck due to arthritis. We were able to have put in an extra wide rear view mirror and extra large side view mirrors, which permitted him to have the same visibility of what was going on around him as if he had normal neck rotation. Newer cars that have the side awareness, back awareness alerts also serve that function. So there are lots of ways of achieving continued independence in a car, but you have to make sure that the car does the work you can't. Next. Okay, so we talked a little bit about motor vehicle risk. I want to talk about medication risk because this is a big one. Up to 30% of hospitalizations among the elderly are the result of adverse drug reactions. And this includes both an allergic reaction, but also a known side effect of the drug, or a drug-drug interaction that has unfortunate consequences. Rules: 1, never, ever take anyone else's medications or supplements. I can't tell you how many people traded drugs when I was in practice, and it used to make me nuts. You are given your drug in the context of your health and your medications, and somebody else's drug is not being given in that context, and it can be very dangerous. Second, among the most dangerous drugs are sleep medications, including over-the-counter ones. Because they're over-the-counter doesn't make them safe. Benadryl for the elderly, taken as a sleep aid, causes significant reduction in reflexes for up to 12 to 20 hours. Drugs that we use for anxiety and depression are also important risk in terms of risk of falling, blood pressure fluctuations, and cognitive impairment. The flip side of that is don't take yourself off a medication without consultation. Certain medications that we give for blood thinning, for instance, or for other use can cause rebound effects if you go off them too quickly. Antidepressants can cause severe withdrawal, even on lower doses if you've been on it for a long time. So if you want to get off a drug, which I heartily recommend if it can be done, make sure you talk to your doctor first, or your nurse practitioner or your PA. every visit with your doctor, it is always reasonable to say, is there a medication I can stop or a supplement I can stop? And if they say, oh, no, 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 say, please look at my list. In geriatrics, the goal is to de-prescribe. The average American over the age of 65 is on 7 prescription medications. The more the medications, the higher the risk of hospitalization with an adverse event. That's not to say you should stop medicines that are important for you and doing something very important for your health and well-being. But it does mean that it shouldn't be rote. Doctors are as guilty as can be of the encrustation syndrome, of just adding drugs and never taking anything away. So ask your doctor to be your ally. Ask him or her or the nurse practitioner or the PA to review your medication list with you. And between the two of you at each visit, decide what, if anything, can go. Next. So last and least, I think, but important nevertheless, is the small stuff. And this is the home first aid kit. And again, we can send you copies of the PowerPoint. Everyone should have an instant ice pack. If you don't have that, ice in a plastic bag with some water and a towel around it helps, but an instant ice pack that you just shake and it chemically is designed to then become very, very cold is a good emergency measure to have. Band-aids, that's obvious, but not just the itty bitty ones for your finger. Older people tend to get larger skin tears or falls and will induce larger abrasions. So get the 3-inch size also. And for the same reason, have a stack of 4-inch square gauze pads. If you are not allergic to it, bacitracin ointment is unlike the triple antibiotic ointments, which are a little bit of overkill. Bacitracin is, and the triples also tend to cause more allergic reactions. Plain bacitracin ointment, if you're not allergic, is a good thing to have for cuts and wounds where you're trying to enhance healing and prevent infection. Hydrocortisone cream for rashes. Again, anything you treat, you got to watch it. If in 2 or 3 or 4 days it's not getting better, off to the clinic you go. Keep that regular aspirin, 325 milligrams in that pack or on your bedside table or wherever. Make sure it's not enteric coated. It's just plain old Bayer or anybody else's 325 milligram aspirin. A pair of tweezers, very useful for removing foreign bodies. Hypoallergenic or non-allergenic tape to hold those gauze pads in place. An ace bandage. Ace bandages do all kinds of things, but they are actually pretty poor for treatment of a sprained ankle. However, they will hold an ice pack in place. They will allow you to create an effective pressure dressing for something that's bleeding, especially if you're on a blood thinner. So it's good to have an ace bandage around. Famotidine, common brand name is Pepcid, is very useful for allergic reactions. It has a very low rate of toxicity, and taken for an acute allergic reaction can be very helpful. Loratadine, 10 milligrams, also, it's Claritin is the brand name, but generics are fine. Taken together, the famotidine and loratadine, if you're having an acute reaction to something until you can get a hold of your doctor, these are useful things to take. And finally, please, an oral thermometer. I would be a much richer lady if I had a nickel for all the times I asked a patient what their temperature was over the phone at 2 in the morning, and they didn't have a thermometer in the house and couldn't tell me. Not only have one, but make sure it works. And it shouldn't be mercury. It should be one of the standard oral thermometers. The ear ones are impossible to use if you're not really well trained in using them. So forget about those. And the forehead ones have a very high rate of unreliability. Next. Okay, so in the last 35 minutes or so, we've talked about falls, heart attack, stroke, car accidents, and medication risks. We've talked about how to prevent catastrophes, but we've also talked about taking an aspirin and calling 911 for chest pain that's suspicious, or calling 911 for fast symptoms. We've talked about having a grab and go envelope and making sure that you also have hearing aids and glasses where you can always find them. and we've reviewed the home first aid kit. And I hope that that's given you some new information and not just been a rehash of stuff you already knew. And if it has, well, then I've reminded you. So that's it. And I think at this point, I'm open for questions.
Okay, let's see.
All right.
One-
Hi, Gail.
1 second, I have to unspotlight Gail here. Okay, Gail, where are you?
I ran away.
You're in here somewhere. Okay.
What's he looking for?
Well, you can
Hold
start
on.
with the questions while David's
Here we
doing
go. Here we go. Okay, remove spotlight. Okay, now Sid, take it away.
All right. First, I think, thank you. That was terrific. And offline, I will communicate with you about taking this on the road. Isolation seems to be a risk factor for the elderly in particular. Any tips for overcoming this?
So Sid, I don't know who asked that, but that's a really
Me.
important issue. It's a really important issue. And you can be isolated in non-COVID times, especially if you're a caregiver or you have mobility issues. So it's not just a COVID related thing. I think this is where the village becomes important, and getting over ourselves to request help from our village becomes very important. Whether it's something like the Wise Aging Group, Montgomery County, I don't know about the district, but Montgomery County has organized groups who call folks who are interested on a regular basis to see how they're doing. I think reaching out to programs that allow you to connect online, like Ollie, which I know you participate in, is important, but then continuing those contacts. This is, again, we are all so trained to be individual, hard-headed, upright, self-reliant people that asking for help is hard. But in the Jewish context, I think it's important to remind ourselves that giving someone else an opportunity to perform a mitzvah is a mitzvah. So calling, several of your friends and saying, let's talk twice a week is fine. Or I would like people to come visit me. Hineni doesn't just have to come visit when there's an illness or a death. Hineni is, I'm here for you. And what more reason to be here for someone than if they're feeling isolated?
Yeah,
But
that's a
you gotta
function of Hunani that I don't think is widely known. And maybe you could speak to that a little bit more.
Well, I think, Hineni literally means I am here. And isolation.
Our Hunani, I mean.
Yeah. So I think, no, I get it. So I think that, but again, the big hurdle here often is that people are afraid to ask. And part of aging wisely is articulating our needs and helping others to help us.
Okay, the first person doesn't ask a question, but offers some information. This is from Nancy. The DC Department on Aging and Community Living has a fabulous program with a grant called Safe at Home. An occupational therapist will come to your home, assess what needs to be done to support you in thriving at home, and everything is covered. Grab bars, shower chairs, raised commodes, and many other assistive devices. Then a contractor will come in and install everything. She's researching to find out if this exists in other jurisdictions.
Nancy, what a wonderful resource. Thank you so much for bringing that up. I honestly wasn't aware of that because most of my practice has been in Montgomery County, but that's wonderful. Thank you.
A bunch of applause here. Any evidence that playing music or doing things like Wordle are more than just fun?
So, that's a really, really important question. And the fact of the matter is that none of these so-called brain exercises have been well enough studied in large enough populations to know. That said, avoiding depression and anxiety do reduce cognitive function. We know that beyond a shadow of a doubt. It's part of the symptom complex. And if doing those things brings you joy and helps alleviate symptoms of isolation or anxiety or depression, then absolutely go for it.
David Diskin comments that he recently learned how important it is to be in the best possible physical shape to heal more quickly
Yeah.
from accidents and resulting in fractures.
Yeah. Yeah. Having the muscles around those bones in good shape makes a big difference.
From Ruth Schimmel, there are over 16 villages in the DMV.
Mm-hmm.
I'm a member of the Foggy Bottom West End Village, which is superb.
Mm-hmm.
And we're also villagers. And just a suggestion that people who aren't might explore that. They
Yep.
offer a lot of companionship and volunteer aid.
Yep. Yep.
Um,
And again, the being a volunteer and aiding someone is good for the soul, and asking for help is a way of avoiding isolation or risk. So the villages are very, very important. Thank you so much for raising that.
well, and on your point, I won't use names, but long ago, a beloved member of the congregation was stricken with ALS. Another member of the congregation at some point offered to take him to lunch. This was a very independent-minded person who had a long learning curve. And finally, he was refused many times. And finally, the offerer said, you know, it's a mitzvah. You are not letting me perform my mitzvah. That got through. They went to lunch. David Diskin, Gail, it's important to chew aspirin versus swallowing it. Could you talk about that?
So you can chew it or swallow it. Aspirin is pretty quickly absorbed when it gets into contact with gastric acid. It gets diffused very quickly. Many people will say to chew it up, but if you have dental issues or you've got oral ulcers, take it with a glass of water, it still helps. Chewing is ideal because it releases the acetylsalicylic acid faster, but aspirin gets absorbed pretty quickly. That's why it causes ulcers so nicely.
Adrian Umansky, is there any reason why we should not have the next booster? And thank you for your so informative presentation.
Oh my goodness. Okay. So the first thing I will say to people is don't rush out and get it right away. Without getting into a lot of molecular biology, getting a booster too early undermines the benefit of it. So that, for instance, if somebody got a booster 2 months after getting their primary series, their immunity to COVID is substantially less than someone who waited 8 months. And that's because of the way the body's immune system works. It needs time to develop the memory to respond to the booster. And if you do it too soon, you effectively are colliding with what's called the acute immune response and not giving the body a chance to develop what's called an anamnestic or delayed immune response. So you should preferably wait 6 to 8 months from your previous booster before you have another booster for it to be optimally effective. The Israeli studies do not show that the second booster substantially reduced the risk of hospitalization overall, especially in healthy elderly. So as a justice matter and a fairness matter, I would say unless you have an immunologic problem or you're in what we call the old group, which isn't a very nice designation, but it's what it is, it's over 85, I would wait and let those folks get their boosters first. And then you can get yours, since I think supplies are going to be somewhat difficult for a while.
Well,
Medically, there's no reason not to get one unless you had a significant adverse reaction to one of the previous shots.
Well, on that point, as you no doubt are aware, the incidence of getting the shots or getting the vaccine continues to fall alarmingly in this country. There's no rush. And so as opposed to, you were concerned about lack of supply. I have no idea whether there is any lack of supply at this point. Can you speak to that?
I think it's variable. It's pockets. We just had a phone call this morning about it. In some places, there's no problem at all. In other places, you can't get a hold of it. So I don't know what the local situation is. My guess is it's pretty good, but I think most people who got shots will just have gotten boosted in September or October. So you're just now becoming eligible. If you call a place and they say they've got lots, go ahead, go for it. If it's been 6 to 8 months, but if it's only been 5 or 4, let other people who are more vulnerable get it ahead of you. It's to their benefit and yours.
Okay, now we have somebody who would like to speak her own mind, and I suspect she has a lot to say. So David, if you'll unmute Mimi, let's hear from her.
I can't unmute her. I can only ask her to unmute herself. So Mimi, please unmute yourself. Or if you can't, put your
I think I'm on.
Yeah.
No, you're good.
Okay, thank you. That was an excellent presentation. I'm glad that even though I came in late, you really did a wonderful job. I have to tell you that the villages, I want to reinforce, at least Capitol Hill Village is phenomenal. I have been sick and they call me at least once or twice a week, find out if I'm okay. They have people doing that. So I think if you're a member of the village, and if you're not a member, you should become a member of your local village. But you also should appreciate what they're doing as such. I want to mention that I once gave my mother, who was in her 90s, a very low dose of Benadryl because she was having a stuffy nose. And as a result of that, she couldn't pee. And I wasn't thinking that it affected, and you can perhaps talk about that, but it was really a low dose. And then all of a sudden, turned out she couldn't pee and she ended up having to be catheterized. So you really need to be careful with giving senior people, even though you're being careful about the giving them medication. Thank you so much, Gail.
That's why I didn't
Go
say to
ahead.
put, but that's why I didn't say to put Benadryl in the first aid kit, for exactly that reason. It's a toxic drug. It's been grandmothered into being over the counter.
Right. But I have to say also that the tempo has been phenomenal with Hanani. Since I was sick, they call at least once a week. So we really have a wonderful resource. It's a mitzvah for them.
Thank you, Mimi.
Roberta Gorin commented about the mysteries of the aspirin. My dad used to say, put it under your tongue and let it dissolve.
No. Don't do that. You'll end up with an ulcer in your mucosa. Not a good idea. If you chew it, follow it with some water right away if you can. And if you can't chew it, swallow it, but don't put it under your tongue. No. There's enough absorption. There isn't just chewing it. There's enough oral absorption, but sticking an aspirin right against something is a good way to get an ulcer.
It wasn't very often. It was just occasionally. And what it did is he said, he was a doctor also. He said it went right into your bloodstream, therefore acted faster.
That's why, per David's point and your father's point, we should chew it, because the oral mucosa is a very absorptive surface. But I don't want people to think, oh, I can't chew it, therefore I can't take it. It's still better to take it and swallow it and get it into your system somehow than not at all. And with all respect, Roberta, in my 40 or 50 years of doing this, there are so many things we told people that we don't tell them not to do now. I mean, we actually do learn from our mistakes sometimes in this business.
Well, this was a long time ago.
Well, with regard to over-the-counter medications, I think some of us have perhaps fallen into a false sense of security that these things are okay. You know, they're out there for anybody to buy. Other than aspirin, are there some common over-the-counter medications that really pack a wallop if misused that we ought to know about?
Benadryl, or diphenhydramine, as it's commonly called. It is a terrific drug, but it has all kinds of toxicities ranging from cognitive impairment to to bladder malfunction, to profound constipation, to severe dry mouth, to vision disturbance. No, 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 not without guidance. And even in pediatric doses, as Mimi found out, if you give it to the wrong person, because you may be on a drug that already has some of those same chemical effects, and you add Benadryl to it, and suddenly you're on a toxic dose. So, so Benadryl is something that I don't think should be in someone's home unless there's a qualified professional telling you how to take it. And you can have it, but don't take it without talking to your clinician first and making sure they know what drugs you're on. The second thing I would say is aspirin. Again, don't take it prophylactically unless you've discussed it with your cardiologist or your clinician, because regular aspirin does increase the risk of bleeding. In some people, fatally. There's an increased rate of fatality among women who take aspirin over a certain age compared to the prevention from heart attacks, for instance. So aspirin is not something to mess with unless it's being taken appropriately. All of the sleep meds include either doxylamine or diphenhydramine and or one other antihistamine derivative. They're all potential dangers for those of us over the age of 60. They're dangerous for 40-year-olds too, but they're particularly dangerous as we get older. We really discourage using anything that's sold as a sleep aid without talking to your clinician, and preferably don't use them.
I can see you're so concerned that you're literally clutching your pearls.
Well, it's just, I mean, if you've practiced with the elderly, then you know that those are reasons why families are calling you at 2 a.m. saying, my mom's really confused. I don't understand what's going on.
Barbara Diskin had this concern. Can you give us any general advice on how to safely take pills? What happens if they get stuck in your throat?
So very often they don't get stuck. They just feel like they get stuck. What happens now, some of us have esophageal motor dysfunction or have strictures or esophageal webs, and then they do get stuck. The only thing to do is to drink a lot of fluid. Sometimes a slightly viscous fluid like melted ice cream or milk works better than plain water, which washes around it. But very often what's happened is it's been stuck a little bit. It caused a small esophageal abrasion or scratch, and then you have the sensation of a stuck pill when it's not stuck anymore. The best thing to do is just to keep drinking, eating soft foods, puddings, tapiocas, cream soups, things like that. And if you're swallowing all of that without difficulty, most pills will disintegrate within a short period of time. If it happens recurrently, you need to go see your physician because it may be indicative of some other malfunction in the esophagus.
Barbara Diskin asks for advice on how to deal with an aging body that is not as regular as it used to be.
I'm going to guess that that's dealing with a particular subject. So exercise is really important. And most fiber products are helpful, and you'll find the one that is most useful for you. Don't fall into the trap of I have to do X, Y, or Z on a specific schedule. Many people are, because of advertising, under the impression that something has to happen every day. It doesn't. If your normal pattern is every 2 or 3 days, that's fine. If it's every day, that's also fine. If it's 5 times a day and that's what you've been that way for your whole life, that's also okay. But again, it should be individualized. You should talk to your doctor. Many drugs cause constipation. And if you're having a new problem of that sort, the first thing to do is to talk to your primary care clinician and see if there's a drug that should be changed.
Oh, on these over-the-counter drugs, Jane Kirshner wonders about melatonin.
The data on melatonin is increasingly unhelpful in the sense that the more we read about it, the less effective it seems to be. That said, there are a couple of studies where elderly people who are taking melatonin had increased fall risk during the night. It's not clear why that is, although it may have to do with changes in sleep patterns. In general, unless you have a very specific reason to take it. For instance, you're doing a lot of international travel and your pineal gland is taking a hit because of the changes in time zones and timing. You don't really, melatonin doesn't do a heck of a lot to improve sleep onset.
Well, I don't know the timing of this event. We do not have any, oh wait, here's another comment. For sleep, medical marijuana has been miraculous.
Yeah, I hear that from a lot of people. I think that it's important to know that the rate of car accidents associated with medical marijuana use has skyrocketed in Colorado and in other states. So I think that one needs to be very careful. We don't have good, what we call pharmacodynamic studies in the elderly, because because this is sort of not an FDA regulated area to a large extent. We don't know the dose that you're getting, even though they think they tell you they know the dose. There's no standardization of dose across agents, and there are no what we call PK and PD studies, which are required for all prescription drugs except for marijuana, which is prescribed sort of. And so we don't know how long it lasts in the body or what its effects on the body. If the same drug were prescribed for the elderly as a major pharma drug, it would have to undergo, among other things, suicidality testing, reflex testing, reaction time testing, warnings about driving, yada, yada, yada. But because of the regulatory loophole that marijuana sits in, none of that happens. So while I think marijuana has a role to play, be aware that you may be playing with fire.
Early in your presentation, Gail, you mentioned the importance of a USP stamp on an appropriate medication. Nothing like that exists, does it, for marijuana?
No.
I mean, there's no standard. You don't know what you're getting.
I want to be clear. I think there are, for instance, there are clinics that deal with chronic pain where CBD has been shown at the molecular level to do some very interesting things in the brain. I'm not saying that this class of medication, and it is a medication, isn't potentially very useful. I'm simply saying that we are in entirely a caveat emptor situation here, buyer beware. And I certainly would never, ever take it upon myself to reassure someone that any amount of marijuana they're taking is safe.
Okay, we're nearing the end here. From Karen Rosen, I suspect that sleep studies are pushed a lot and have very little value unless you have respiratory issues. Comment?
This is a case of a discovery phenomenon. Because we are able to find it, we have now learned that many, many people have sleep disorders. I think that in the hands of responsible sleep doctors, if you have daytime sleepiness, if you've been in a car accident, there's a much higher rate of car accidents among people with sleep disorders. If you have other limitations during the day, typically sleep disorders do not present as daytime respiratory issues. But if your spouse can't sleep because you're making a lot of noise, that's also an indication to get a sleep study. Your spouse needs sleep too. So I think it's not all hokum, but I do think it may be the disease du jour to some extent.
From Ruth Schimmel, when and where will the recording and slides be available for the outstanding presentation? I'd like to share it.
So the recording should be available the next day or two from the MICA website. I have to upload it after this, and then they put it up on YouTube. And as far as the PowerPoint, if you need that in addition to the recording, Barbara, you want to can we just send that out to everybody who participated today? We'll do that. She might be muted, but we'll do that.
Okay.
I think that's a nice way to sum up.
Great presentation. Wonderful job.
Thank you.
Mimi. That means a lot coming from you. Thank you.
Thank you.
Thank
was
you very
great.
much, Gail. It's been terrific.
Well, thank you all for listening, and thank you for giving me an excuse to review all of this. I appreciate it.
Great.
Okay.
Bye-bye.
That's, I think that concludes our meeting.
Bye,
Bye-bye,
everybody.
everybody.
Bye.
Everyone.
Bye.